Good evening and welcome everyone to the symposium titled Geriatrics in the Time of COVID in the Asia-Pacific region. This is a 1-hour session. We'll have 12-minute presentations from 4 speakers, leaving the Q&A to the end. So the first speaker is myself, talking about the Hong Kong experience. The second speaker is Associate Professor Lim Wee Seong, who is the director of the Institute of Geriatrics and Active Aging. His talk is on caring for the caregivers of persons with dementia. The third speaker is Dr. Tan Mau Ping. She is the professor of geriatric medicine at the University of Malaya. And she will talk about care home deaths from COVID-19 in Malaysia. And last but not least, the fourth speaker is Ariana Suka, and she will talk about developing an integrated community care hub for older people in Indonesia during the COVID-19 pandemic. She works at the Udayana University Teaching Hospital in Bali, Indonesia.
Thank you very much for this opportunity to speak at this IAGG symposium. Together with my co-author, Dr. Noor Haslina Ali, we bring you greetings from the city-state of Singapore. In this talk, I'll be sharing the Singapore experience in caring for caregivers of persons with dementia during the COVID pandemic. For the purpose of this talk, there are no financial disclosures to declare. My only disclosure, to paraphrase Roslyn Carter, is that I have been a caregiver, am still currently a caregiver, and am in no doubt that I will need a caregiver in future. Indeed, this audience needs no reminders about the immediacy and relevance of caregiving. My outline for this talk will focus on 3 points. Firstly, an overview of the impact of COVID-19 on caregiving, followed by a sharing of some initiatives in Singapore, and wrapping up with personal reflection. Similar to many countries worldwide, Singapore also has a rapidly aging population. The prevalence of dementia in those aged over 60 is estimated to be around 10%. When we consider only those aged 85 and above, this figure increases to 1 in 2. It is projected that over 100,000 will be diagnosed with dementia in Singapore by the year 2030. Caregiving responsibility has fallen squarely on the family unit. This is due to the collectivist culture typical of many Asian societies, where filial piety is an esteemed value. On the practical note, family members constitute the largest invisible workforce which can be harnessed to meet the burgeoning need for caregiving. In Singapore, family caregivers mainly comprise spouses without children. Other family members such as siblings, grandchildren can also be involved. Another unique feature in Singapore is the reliance on paid informal help in the form of foreign domestic helpers. In a 2017 study, it was estimated that the mean annual cost of informal caregiving was around 40,000 Singapore dollars or USD 30,000. In the last 2 years, the COVID-19 pandemic has required a fine balancing act between successful pandemic control on the one hand and mitigating secondary adverse consequences to older persons on the other. Besides the direct impact of COVID-19 on medical complications and mortality, we now recognize that public health measures can have secondary and unintended consequences on older persons in terms of physical, mental, and psychological well-being. To understand the impact of restrictive pandemic control measures during the circuit breaker period on exacerbation of behavioral and psychological symptoms of dementia, the Memory Clinic in Tan Tock Seng Hospital conducted a clinical audit study that compared the pre-circuit breaker period versus the circuit breaker period in 2020. We examined the electronic medical records of persons with dementia who attended clinic consults during this period. We found that there was a significant increase in disruptive behaviors during the circuit breaker period, which was related to COVID-19 policy measures. In addition, there was a concomitant increase in caregiver stress and the need for adjustment of psychometric medications. The British Ideal Cohort Study gives interesting insights about the impact of COVID-19 on caregivers of persons with dementia. The caregivers did not report issues related to competence arising from caregiving. Rather, issues pertain to the fragile support system if they fell ill or needed a break. Caregivers also report role activity in feeling trapped in the caregiving role. Thus, during COVID-19, predisposing factors for carer stress include longer hours of caregiving at home from disruption of usual routines and closure of daycare centers, lack of adherence of the person with dementia to mask wearing and safe distancing measures, worsening of behavioral symptoms, grappling with information overload that may be conflicting in terms of messaging, resources, and policy, and lastly, compromised physical and psychological well-being from sedentary behavior and increased social isolation. Not surprisingly, as this headline title of one of our national papers suggests, COVID-19 inflicts more stress on Singapore carers of people with dementia. So, what is the Singapore response? In line with the Caregiver Support Action Plan by the Ministry of Health, the COVID-19 adversity has spawned initiatives that pivot on technological advances and inter-organizational collaboration to support caregivers. From the policy perspective, there are flexible work arrangements and financial support in terms of home caregiving grants. More impressive are the bottom-up initiatives, which I have classified as practice, programs, and plays. Firstly, practice, which refers to community initiatives developed to help caregivers. SPOT19 provided identifiers for persons with dementia should they inadvertently break rules such as face mask wearing and safe distancing. DimensionHub.sg is a one-stop online resource portal with curated content for different groups, including caregivers of persons with dementia. There are many resources, including this recipe book, which has a collection of caregiver recipes and stories to care, cook, and inspire. CARA, which means Community, Assurance, Rewards, and Acceptance, is an initiative by Dementia Singapore, which provides a lifestyle and community digital platform that connects to an ecosystem of solutions via a mobile application. Each member is provided with a unique membership card, which has a unique QR code to aid the safe return of persons with dementia should they get lost. Moving on to programs which were developed during COVID-19 to help caregivers cope with complex care. Post-diagnostic support is a philanthropic funded program for caregivers of persons with dementia who are newly diagnosed. Using a personalized care plan, newly minted caregivers have a coach to help ease them into the first year of their caregiving journey. Another development is the local adaptation of the Namaste Care Unit toolkit for delivery in long-term care facilities. Namaste Care is a multi-sensory person-centered intervention program premised on the principles of loving touch, meaningful activities, and a calm environment. The emphasis on family participation is especially salient in Asian societies. In this study of patient-family diets in a subacute ward, family members perceive that Namaste Care improved quality of life of their loved ones with dementia, cohere strongly with Asian family values, and empower them to make a big difference through small actions. Lastly, to enhance care of persons with dementia during their hospitalization, there was interdisciplinary collaboration between geriatricians and infectious disease experts for delirium prevention in the acute wards. Enhanced delirium care pathways include systematic delirium screening, optimizing sleep and cognitive stimulation, and minimizing pain, tethering equipment, and sensory deprivation. Finally, place refers to innovations making the home and external environment dementia-friendly. Hack is an elegant magazine modeled after the IKEA catalog. It provides ideas on dementia-friendly designs, which came in handy during this period when persons with dementia spend more time at home. The Virtual Reality Dementia-Friendly Home Design Guide provides caregivers with an interactive virtual platform which proposes modifications to create an accessible and safe dementia-friendly home. Floor murals of color-coded arrows linked to familiar childhood games were pasted at busy bus interchange to help persons with dementia find their way home. In closing, COVID-19 has been a challenging time for carers for persons with dementia. In many ways, COVID-19 may be the perfect storm with the confluence of many challenges. However, it may also provide the perfect opportunity for innovation to care for the carer along the 4 Ps of practice, programs, place, and policy. I will end with this thoughtful quotation written by Matthew Cesare at the height of the COVID pandemic. He asked, what will remain after COVID is defeated? In the same way that the perfect storm may herald the perfect opportunity, Albert Einstein views crisis as the greatest blessing for people and nations because crisis brings progress. Hopefully, we will learn from mistakes and contribute for a better society. The society able to give more value to persons with dementia and their caregivers, independently of their age. I would like to acknowledge some of the organizations mentioned in my talk, as well as my clinical colleagues at the Department of Geriatric Medicine and my research colleagues at the Institute of Geriatrics and Active Aging, Tan Tock Seng Hospital. Thank you very much.
Thank you for this opportunity to share with you the story of COVID deaths in care homes in Malaysia. Malaysia is, of course, very famous for its twin towers, and we are now building the second tallest tower in the world. I wish I have time to tell you more about our wonderful country with a hot climate, just like Argentina, and we also have a population of about 35 million, and most of them are younger, so we're only an aging population, and about 10% of our population are now over the age of 60, 60 being the cutoff age for older people in developing countries. So today, instead, I'm going to first of all, refresh you on the international COVID-19 care home statistics so that you have something to make the comparisons with, and then actually highlight to you the problems with COVID-19 in care homes in Malaysia, and bring forth the strategies that were introduced to reduce transmission of COVID-19 in care homes in Malaysia, and then, of course, the statistics you're all waiting for. The first three I'll do quite quickly so that we can concentrate on the last point. So just a refresher. COVID-19 deaths in care home is really has been totally disastrous. I took this figure from the LTC COVID website. Adelina has been tremendous in actually facilitating the sharing of information on COVID-19 in long-term care facilities throughout the world. And we had contributed some of our data to her website as well. But we didn't have enough data to actually produce this figure. And as you can see, most of the data came from Europe, with a bit from Australia and a bit from Canada. So, and everyone probably knows that Canada holds the crown when it comes to percentage of deaths from COVID coming from care homes in the first wave of the COVID-19 pandemic. 85% of their deaths came from care home in the first wave. Well, they did much better in the second and third wave. Overall, wave 2 Australia deaths from care homes actually comprised over 80% of all COVID deaths in the second wave of COVID. But as you can see, in all these developed nations, primarily from Europe and also from Canada and Australia, the percentage mortality of the total mortality from care homes was high, ranging from around about 20% to about 85%. So COVID in care homes in Malaysia, however, tells a slightly different story, but to me, it's quite disastrous as well. So basically, this actually is a little bit about COVID-19 in care homes. Case fatality rates of 0 to 33% have been reported in residents, and asymptomatic carriage has been reported in up to 75% and up to 100% of staff in these care homes. And these are the symptoms. So in a care home, you're mainly looking for confusion and atypical symptoms. They may not necessarily present with classical symptoms of fever, cough, or shortness of breath. So in care homes, a lot of the cases started from COVID positive cases discharged to care homes in the first wave, especially. Particularly in developing countries such as Malaysia, there are great challenges because these are pretty overcrowded places in order to reduce the cost of rental. So physical distancing is a challenge. And many of our patients in care homes, in our residents in care homes, actually are unable to comply with infection control practices, either due to physical disability, but more often because of cognitive problems. There are lack of isolation facilities, so they're pretty much done if more than one person has COVID, because they only have one isolation bay. Wherever, no matter where in the world you are, the provision of PPE has been lacking, and the staffing issue is becoming increasingly acute in all care homes worldwide, and in Malaysia it is not at all. We are not excluded when it comes to this. And then when it comes to the size of care homes, it does look like larger care homes suffer more when it comes to COVID, because I guess more people, more chances of someone bringing it in. And perhaps some of the Malaysia got off lightly because many of our care homes are rather small in size. So this is a story about care homes in Malaysia. There are 17, literally 17 government-funded care homes, 15 residential care facilities, and 2 nursing care facilities, and that they actually supply about 700 beds in total. There are 350 registered care homes in Malaysia, and possibly more than 1,000 unregistered care homes. Our care homes can be old folks homes, which are residential homes, and most of those are actually funded by religious organizations and NGOs, as well as nursing homes, which are privately funded and are more equipped for heavier care. So this is a typical nursing home in Malaysia, many beds in one room, limited space between the beds, and it's generally clean, but that's it, quite bare basics. So Malaysia did come up with initiatives such as mass testing, and we did that only on one occasion, and this is a picture that they shared with me from the Nursing Home Association. So these were the policies we put in place. All care homes needed to test temperature twice daily, but most of them did it 3 times daily, and also did a symptom screen in all our residents 3 times a day. They avoided new admissions initially, but that became very difficult. And so new admissions were always tested and isolated for at least 7 days before they actually moved in with the other residents. No visitors were allowed throughout the pandemic, and that is still very much restricted, but easing happened last month. All hospital discharges to care homes were tested after the initial debacles. Isolation, barrier nursing was for 7 to 14 days, 14 days if it's possible. And then no communal dining, no group activities, and maintaining of social distances. And in fact, all care homes were locked down throughout the pandemic with intermittent easing, but it was never fully eased off until this month. And then any positive cases were actually moved to hospital because of the difficulty in isolating until hospitals ran out of space in mid-2021. So we had acute staff shortages, with the Ministry of Health suddenly calling back a lot of the nurses who were waiting for placements and working in the care homes. Many of them had no new admissions and reduced donations if they were NGO run, no PPEs, as mentioned before, confined spaces, and many of them were hiding from the authorities because they were unregistered entities. And these were the key initiatives. The HCOPE is our Nursing Home Association, who actually maintain communication with the members throughout. We developed interim guidelines, and then that was quickly followed by the Ministry of Health guidelines. And then the Department of Welfare provided one-off cash payments of 8,000 ringgit, which is around about $2,000 to help them get through the initial financial difficulties. We also had WHO funding to actually develop an infection control module for caregivers in these homes. And then when things got too bad, Malaysia actually opened up dedicated geriatric COVID facilities for isolating these people until they got better and went home, and some of them actually died there. So the statistics. The orange line shows the number of homes with outbreaks throughout the pandemic. So it started in March 2020, and the latest I provided was up to 30th of April 2022. But of course, not all cases have been reported. We use the cases where the outbreaks ended, or the dates where the outbreaks ended rather than reported, because sometimes the reports came about up to 2 weeks after the outbreak had ended. And then we also looked at total deaths, and as you can see, the outbreak, it didn't really happen much after the initial debacle of discharging patients with COVID-19 inadvertently to care homes. We started swabbing regularly, and then it didn't really happen much until the second wave. There was a small peak in outbreaks, and then the third wave was totally disastrous. And on the top box here, I'm showing the vaccination policy program in Malaysia. Phase 1 was for healthcare workers and frontliners, and that started in February 2021. And phase 2 was supposed to be for senior citizens and other vulnerable groups, and that started in April 2021. But as you can see, the peak happened after the start of phase 2 and occurred actually to the end of phase 2. That was because there was a delay in vaccinating care homes, and they never really all got their vaccines until August 2021. And that's why we had this big spike with a peak of up to 63 outbreaks in September 2021, and 125 deaths in August and 125 deaths in September. While these numbers may seem small compared to a Western country, only 1% of the Malaysian older population lives in nursing homes, care homes, and therefore only 30,000 care home residents in the whole country. And these, of course, the outbreaks numbers actually contain staff as well as residents, but none of the staff died, so most of the deaths would have been from residents. Okay, and this is actually a newspaper article showing care home vaccination. So they eventually got to the care homes in July, and when they got there, they were very disappointed because not all of them actually agreed to be vaccinated because of issues with consent. Okay, and this is actually the vaccine uptake in Malaysia. Vaccine uptake is very good. We've got 35 million population, and we successfully fully vaccinated 2 doses, 80% of all our population and 97% of the adult population. So this is the total number of cases, again matched with the vaccination phases. As you can see, the peak was at 3,666, which represented about 10% of our care home staff and resident population at its peak. And then test positivity, as you can see, there was an effort to mass tests towards the end of 2020, and therefore you had 38,000 tests in that quarter. And the positivity rate then was round about 0.7%. That was in October 2021. But as the time went by, there was less and less testing in these homes, and we had positivity rates of up to 66% in November 2021. Mortality rates, initially, high mortality rates in 2020. We got better at treating them. So the mortality was a bit lower in 2021. And in 2022, when everybody eventually were vaccinated, mortality is low. And the booster hasn't really got to the care homes yet. We hope they'll get there soon. Okay, so this, in comparison to COVID-19 deaths in Malaysia, the peak of the care home outbreaks corresponded to the peak of deaths. And as you can see, most of the deaths actually occurred in adults, and proportion of population wise, because older people over the age of 60 only comprise 10% of the total population, most older people were far more likely to die of COVID-19 as well in Malaysia. So in summary, we had 434 clusters from care homes that actually exceeded the number of registered homes. So I would well imagine that many of the outbreaks occurred in unregistered homes. 17,248 cases, which actually really we're talking about nearly half of all residents and staff in care homes actually being infected with COVID. In Malaysia, about 10% of our population has 10 to 15% of the population has had COVID in comparison. And then test positivity, 17%, which is actually far, far higher than the natural average. You know, usually our positivity rates are around about 5%. And then deaths, 1.2% of all deaths occurred in care homes with a case fatality rate of 2.5%. Really, which is not so bad. Compared to a lot of developed countries, but it's probably because many of our care home residents are not really needing nursing home cares. It's just that they have no relatives, so they're not really have multiple medical issues, and therefore that might explain some of the low case fatality rates. But of course, quite a lot of underreporting is also possible. Thank you very much.
Ladies and gentlemen, it's an honor for me to have the opportunity to present in such excellent meeting. I would like first of all thank the organizing committee for inviting me here today. Let me start by saying just a few words about my own background. I am Dr. Suka. I am geriatrician from the Geriatric Division in Internal Medicine Department, Medical Faculty of Udayana University, Sangla Teaching Hospital, Bali, Indonesia. So my focus presentation today is developing of integrated care hub for older people in Indonesia during a COVID-19 pandemic. The aim of my presentation today is to give you an overview of current condition, need and policy of the elderly in Indonesia during COVID-19 pandemic, and also introduce you to my current pilot project that called the Integrated Community Care Hub, or ICC8, for the older people, and I will be explain also to you how important this program to our elderly in Indonesia. And if there is something which you need to clarify regarding my presentation, there will be the time question after the presentation, and I would love to answer them. Okay, this is the outline that I will be present. The first, I will talk about the current condition, need, and policy in elderly in Indonesia, and second about the concept of the integrated community care, and the third, of course, that is how to running the pilot project integrated care community care hub for the elderly people. And okay, this is the first. This is in the introduction. That this is our country. The projection of elderly population in Indonesia will be increase very rapidly, and in 2045, that almost all provinces in Indonesia will have elderly population exceeding more than 10%. Evenly in some provinces, will be above 20, and this condition is certainly is a challenge for Indonesia, especially in Bali, where I live. This is a high number too. And luckily, that is Indonesia still has a population bonus with the expected to be potential able to strengthen the country resilience to face the challenge of this elderly explosion. And because of that, our Ministry National Development Planning in Indonesia, we call it is Bappenas, is already have successful developed an elderly data information system that we call Silani. Silani is the integrated digital data platform for elderly need and service. Silani start trial in 2019, conduct in 7 villages, 2 villages in Jakarta, 3 villages in Yogyakarta, and 2 villages in Bali also. Then the number of sample is quite big. This is good data, around 14,000. And Silani is this initial project that has become basis of implementation of the ICC8. So it is the basis of the integrated care community care hub project for other people. So let me see the data of the Silani trial on 2019. Okay, I'm sorry. This is the data of the Silani, and Silani perform is a screening to elderly based on the disease or disorder, based on limitation of HDL or EADL, psychological problem and cognitive problem. And this result that is 9.7%, the level is the elderly is in level 3. So it means is a defensive group and required to care, support, and assistance. So this number is quite big, and of course the other side is the condition is still in active condition, so but still need also in active program active program. So this number of 9.7% will need have and care for their own family, but 12% who do not have an elderly companion. So there is the problem why this pilot project is very important for them. And this is the idea to create of the integrated community-based service for AIDS care emerged to maintain and to improve the quality of life in the elderly and remain in a community and in a family. So we concerned about to support about the aging in place, and we hope that is the quality of life of elderly people with this program will improve day by day. And what is the vision of this program? The vision is the program is integrated service, not just the integration between horizontal and vertical service, but also how to make that all the program, all from the minister of the social, from the health minister and other, that will be integrated in the village. So that means that the ICC8 care is a center of the service in elderly based on the community. And there will also integration or referral system between the community association, between the healthcare center and clinic, and also the hospital. So it means that is in the village that is will be build the the service integration of the all service for the elderly people will be integration. And how the running of this project. In this project, the training module was developed that was carried out on the field official, cadre, healthcare professional, and also for the community appointed by the officer in the ICCH. And the module is consists of 5. The first is about the base of the ICCH. What is the base of how to care the elderly? And also this is the second about the how to make the integration of the care for the elderly people. And the third is about the case management. The 4 is about how to make a good team, and the 5 is about the clinical problem, how to resolve the clinical problem in elderly. So we have 5 modules. The module was developed to improve stability participant who will work in the ICCH as a team. We improve not just a hard skill, but also a soft skill. And the learning method is not only the lecture in discussion in the class, but also practice to the field and dealing with the elderly accompanied by national consultant. There are online and also parallel joint class session in each village with the offline. And during the pandemic condition, that everyone should follow the health protocol, and weekly should be checked the COVID PCR swab for the screening. So that is we can still done the offline meeting or offline conference. And this is the concept of the organization structure used in ICCH, that the principal consists the operational manager, case manager assistant, and senior case manager. A senior case manager is come from the healthcare professional, and usually that operational manager will be leading of a service relation in the operation in the ICCH. Okay, this is the last slide. There is a development of innovative integrated community care hub for the filter of the older people. Is the impact is how to reducing the property and also inequality that be a vulnerable population such as in the elderly, and elderly is the result that the elderly who need care support to live healthy and a meaningful life. This is the outcome, and also the implementation. We starting from the 2020 until 2024, and we doing the pilot project is in 3 villages in Yogyakarta and also in Bali. Then we hope that this will be spread to other villages also in all as a rule in our country that we can doing in every village in Indonesia. So this is some of the picture activity in ICCH. This is the classroom. This is a home visit to the elderly, and also this is can doing the referral to the primary healthcare, also to the hospital, and the activity it can be online, also offline meeting. So that's all. I think that's and this brings me to the end of the presentation. So allow me to to thank to Bappenas, to the national and international consultants, survey matter, and also this participant in this pilot project in the 5 villages in Jakarta and also in Bali. I hope you will have again insight to integrated community care hub for the elderly people during COVID pandemic. So again, thank you.
Thank you, everyone. I hope you all enjoyed those talks. I certainly did. I have some questions for our speakers. And I think it was very interesting, firstly, as an observation, how we had talks today from a wide range of Asia, where there's quite a lot of difference in the development of the countries we've seen. Whereas I think Singapore and Hong Kong would be considered developed high-income countries. And Malaysia is right at the top of the middle-income countries. I think nestled between, on a per capita income, nestled between China and Russia, I think, is the Malaysian income at present. And Indonesia has a lower level of income and therefore has quite different problems. I was wondering, I'd start with Maw Pin. Malaysia is sort of like at that juncture between almost a developed nation, but not quite. Do you think that changes the response to COVID that's been in care homes? Because you said that relatively few people are in care homes in Malaysia, and yet it seemed that the care homes did pretty well, really, as far as mortality and other things. Do you want to comment?
Yeah, we had all sorts of problems during the COVID pandemic in that we changed government twice, but what was really quite remarkable was our desire to protect the vulnerable group, and so the older people had a lot of support from the community. So we'd like to call it like the Malaysian spirit, despite all the lack of government cohesiveness, really, and all the vaccination actually only took off in the care homes when the NGOs and individuals actually intervened and basically went to pick older people up from their homes and deliver them to the vaccination centers. So there was a lot of Malaysian spirit going on that I suppose are remnants of what you would see in a developing country when the government wasn't delivering in terms of what they should be doing. We would expect a higher middle income country government to actually be able to deliver. So in the end, we had the best of both worlds. But having said that, the mortality rate for COVID in Malaysia was actually the highest in Southeast Asia at one point. So I wouldn't say we still are. And a lot of that is due, we have put down to just the government being, say, incompetent. And that's why they were replaced. Thanks.
All right. Carolyn, I was also conscious from your talk there is this tension about trying to get infection control and also the effects it has on the community. And I think that was very much found in Hong Kong because, correct me if I'm wrong, but you've got quite a large part of the population in residential care. Is that right? So
Yeah.
how did all that work? I mean, did you think there was that tension between the epidemic control and trying to look after people? And
so first of all, Hong Kong does have the highest nursing home or institutionalization rate probably in the world. So we're standing around probably 7 to 8%, and Singapore I think is only about 2 to 3, right? So we're way above. And as you know, Hong Kong has long lifespan. Okay, so most of these very old and frail people, because of the environment in Hong Kong, the living spaces are very small. They can't stay with their families, so most of them do go to nursing home. So that's A. And the second problem that we had was actually the very poor vaccination rate. Okay, so it was running around 20%. And you know, Hong Kong has been facing a lot of political challenges in the last few years. So basically, people were distrustful of the government, and if the government set a vaccination policy, then a lot of the initial problems we had was to get people to vaccinate. And the nursing home residents were not spared of that as well. So a lot of families refused to give us a consent. The nursing home standards, we don't really have regulation standards. I mean, supposedly we have, but if you come to Hong Kong and you see the nursing home, the standards are not so good, very crowded. So you can just imagine it's like setting a fire on unprotected, unvaccinated old people in a very close environment, unvaccinated. So I think our case fatality is almost similar to UK. So it's about 0.77, the case fatality rate. And if you're talking about 80 years and above, the mortality, which is mostly nursing home residents are 80 and above, you're talking about 18%. It's very high, 16% to 80%. Yeah.
Wow, that's very impressive. Was it the lack of vaccination? Was it the distrust of people, of the government, or distrust of the vaccination? Why did families not want to get their relatives vaccinated?
So initially, as you remember, Hong Kong had one of the lowest COVID, even compared to Singapore. So it was only in the fifth wave, right? So up to the subsequent, before February or before January this year, we were one of the best performing countries. So with that kind of confidence, there was no reason to get vaccinated because, there was no COVID in Hong Kong, and people were distrustful of the government. Vaccination can be very political, right? And anything that the government says, the people will kind of object, right? Because of the political climate. And secondly, because we had no COVID, or very little COVID. Okay, and coupled together, that meant that actually our vaccination rate for nursing home residents was 20%. At the time when the outbreak took place in January, it was just 20% of nursing home residents were vaccinated. And also we have two types of vaccination. I have to say, we have the Chinese vaccination, which is an inactivated vaccine. And then we have the mRNA Pfizer BioNTech. And the majority of people have this understanding, or they think that, I better go for the inactivated vaccine because that's flu vaccine. So you can argue that, maybe the protection wasn't so good.
Wei Xiong, in Singapore, you have very impressive sort of standards and income, but often the staffing of rest homes and of community services are from immigrant labour. Were you able to maintain immigrant labour during this period, and was that a problem? And how did all that work?
Yeah, Leon, you're spot on. I think it was a difficult time for everyone, and I think during that period of COVID, there was a need to really engage these staff who actually were from other countries. Yeah, and I think when we had our first wave of the nursing home residents being hit, thankfully there was a fairly quick response. I think the experience with SARS was very helpful because I think by and large Asian countries took COVID very, very seriously and understood the need to really treat the vulnerable group of nursing home residents differently. So those who are identified were actually sent to facilities to be isolated and treated rather than cohorted together as if it was the common flu. So for this foreign staff, I think there was really a lot of engagement. And I think the main difference between this time and SARS was that in SARS, there was initially a lot of public fear. But this time around, surprisingly, there was an outpouring of support from the public as well for healthcare workers. And that also includes our workers from other countries as well. In Singapore, as you know, we also had an outbreak in the migrant worker dormitories as well. Yeah, and that was really difficult. And but ironically, I think that helped to shift the mindset of Singaporeans in two ways. One, people then were more open to vaccinations because they saw that we were vulnerable. Yeah, I think one of the infectious disease clinicians spoke about the curse of the zero case. sometimes with the zero case, it's very difficult to convince people to go for vaccinations. I think the second was that it really forced us to really think about contingency plans and move us forward towards the mindset of living with COVID rather than a zero COVID policy. So ironically, I think that was a blessing in disguise and really helped us. But it was a difficult time at one time because, as you know, the numbers were really going high. And I think even though the local situation was very stable, right, but there was a lot of need for a lot of dialogue between government, healthcare workers, and other elements as well. Yeah.
Now, Suka, thank you, Wee Shong. Suka, that's a very impressive module, but it's only in a few provinces. Is that right? Most of Indonesia doesn't have such lovely modules of care. How are things going with that? Is the government going to put them forward to further expand the programs to other provinces? And I mean, Bali's wonderful. We all love visiting Bali, but got to go somewhere else too, doesn't it? Or
I think this is what we call is a very interesting program, and I think the government is interest also, and in Bapenas, this is Minister of the development in national development, so make a collaboration with other ministry, because that before that some other ministry is make a different program for the elderly people. Social ministry have other program, health ministry have other program. So we try to combine them integrated in the one village. So we hope that this pilot project will be success. So we try with the 5 villages in Indonesia, 3 villages in Jogja, and 2 villages in Bali, and of course we'll spend in other village in Indonesia, of course, because that is the result is very interesting, because we develop the community base. I mean the human resource in the community, in the village, from the not just from the health human resource, but also the other human resource in the village. We train them in the 5 module so they can care the elderly in each village. So I think it is one concept is how to make that is the elderly is in the aging place, so will be more easier rather than we put them in the nursing home.
I did see that you found quite a lot of people who might need long-term care, but yes, you don't have virtually no provision of long-term care at this stage. Is that right?
Yeah. This just the integrated, and some people in the village doing activity or service in elderly to see in their home, and also to invite them to come to do some activity together. Yeah, something like that.
Now, we've only got a few minutes left, and so I thought we would spend that last few minutes looking to the future. So I thought I would start with Carolyn. I'd start with the first person I asked. What have you learnt for the future? What is your take-home message from your experience about what we can do better in the future?
I guess one word, I suppose, vaccination, and how to communicate with the public about that. Yeah. So I'll keep it simple.
Yeah, and does that mean you have to do mandates? We had a lot of mandates in Australia about vaccination. Did you try mandates?
Well, actually, you know, when you're working in a nursing home, right? I mean, or you're talking about policies governing nursing home, there are 3 agencies involved. So I work for the hospital authority, right? And my part is because I'm an outreach team to the old homes. But actually, the government or the agency is actually social welfare. So they have set mandates, but to actually implement it and to execute it is the problem. Okay, and then there is another agency, the Public Health Agency. So I think the other thing that if I were to talk about it in something that I learned from a managerial or government point of view is that you need to coordinate all these agencies, which I think Singapore has done very well.
Morpin, what have you learned? What have you learned, Morpin?
Yeah, that's interesting. I think we need better government. That's a key thing. And at the moment, the government tries to control everything centrally, and therefore that led to total and utter disaster because nobody would move in the government sector would move until one person says go. So and that the people then took things into their hands, and then because nobody moved, nothing happened, and the government couldn't actually stop people taking things into their hands. So I'm not sure having people taking things into their hands in the future is actually a very good idea. And what we need to do is to have government devolve power, enable individual districts, individual states to actually call the shots such that they can mobilize the resources that they have rather than rely on absolutely people taking things into their hands. So that's, I think, what we've learned. Yeah, but devolving government is actually a very tricky thing to do at the moment when people are actually trying to hold on to power. So things are evolving, and I hope they will evolve for the better.
Wee Xiong, what do you think?
Well, I thought I'll share it. Okay, I thought I'll share the 3 A's for geriatric healthcare professionals, which are advocacy, alliance, and application. I think there's a need for us to speak up for the older adults, because if no one speaks up for them, who will? And who is in a better position than us, who is in this field? The second is alliance. I think it's important for us to foster relationships with those in positions of influence, but also with the public as well. Because at the end of the day, it's really about that trust that enables things to move forward. And lastly, application of evidence-based practice. And I think here I would again like to have a shout out to research. It's so important with research and data because that is what really convinces policymakers. Thanks.
And Suka, you've got a minute. What do you want to say? What's the future hold for Indonesia and COVID and the world?
After the pandemic COVID, I hope that is what we call elderly population in Indonesia is growing up very fast, and the how to train the people that the different background educational is challenging for us, and I think that all the people should know how to care the elderly people. I mean that anyone who know how to be a caregiver. So it is important because we will have family with the elderly patient, and we should know how to care them. And after that, how to integrate it all the service for the elderly people.
I think that's a lovely way to finish. I'd like to thank our 4 speakers who've been really great. And I'd like to thank the audience out there and hope to see you at the rest of the meeting.